Surgery of the day. We're live streaming. This is a cervical Deuk laser disc repair. Our patient travels to us from Pittsburgh and has pain in the neck going into the shoulders, along with numbness and tingling in the hands. He has 4 herniated discs in the neck. We're going to be repairing all 4 today. He's had prior neck surgery by Dr. Joe in Pittsburgh. All right, we're going to get started. So before I do anything, there's C2, 3, 4, 5, 6. That's without pull or with pull?
Pull. That's with pull, yeah.
Are we going to be able to see 6-7?
Maybe, I don't know. We'll see. It's going to be very, very close to the DC.
Yeah, he's a big guy with big shoulders, so hopefully we can get to 6-7.
By the way, can I have actually...
Fully relaxed. And blood pressure for cervicals can be higher. It's lumbars and thoracics that it needs to be below 110. Huh? All right. So I can feel the spine, which is the first step. It's very important. Let's get a shot. 2, 3, 4, 5. So that's perfect placement. We'll start at 4, 5 shot. 2, 3, 4, 5 shot. Get an AP. Quick AP. So quick AP is a front back view. We use x-rays to navigate. That looks good. I'm going to go a little more medial. Done. Lateral. So I'm adjusting the position of the needle entry point based on the x-ray view of the spine. And to me that looks quite perfect right there. Shot. Yep. So get another AP quickly. So it looks good on the side view. I want to make sure the front back view is good. I want to be basically about 1 centimeter left or right of the midline. So I'm a little bit too far to my side with that one. No, stay there. Shot. Hopefully that's better. Shot. That looks good. Lateral. So I'm happy with the front back view. I'm more towards the center of the spine where I want to be. I want to enter the front of the disc in the center of the spine as close to the center as possible. That looks really good. So I'm going to enter the disc. Shot. All right. And I'm going to do a coker. And I'm going to get an AP view just to make sure it looks good on the front back view. 2, 3, 4, 5. Everybody agree? That looks perfect. Now you can see he does have some scoliosis. Now, he's got a really thick neck too. So the question is, do we start with doing these 2 and then move on to the bottom 2? I think that's probably going to be the best option, right?
Yeah.
Rather than placing the needles and manipulating the neck. Yeah, you can already see the needle is backed out a little bit, so we don't want that. Shot? Yeah. I think we're going to do 3, 4, 4, 5. We'll come out, and then we'll go to the bottom disc. So I think that's going to be the safest way to do it. Yeah.
He's got pretty significant functional improvement, standing up straight, walking better.
But the pain in that area?
Relief in that area, yeah.
So do you think it couldn't be muscle, right?
This, I think, proves that there's at least a strong component of facet pain there.
All right. And when do you think the maximum response would be?
I think at least 50% of his pain right now may be coming from those joints. So I think it's very possible that he could have in combination with surgery.
But do you think it's going to get better in another 30 minutes, or is it maximally improved right now?
Usually right now it's about maximum.
Will you go back there and just one more time, just put your fingers over the facets and push on them, and just say the pain you had in here, how much of that is gone, and just get the maximal percentage, and then document it, let them know, and then I'll come talk to them later. Thank you. Thank you, everybody. All right, so we're on the right side of the neck. We are at C4-5, and we're just discussing the plan here because the most important thing is safety. And my goal is, the hardest part of the surgery is getting into the disc safely. Once that's done, like we've done here at 4-5, the rest is easy. Did you show them the endotracheal tube and the esophageal temperature probe? That would be good to do because we're displacing those to get into the disc. Yeah, there's the endotracheal tube. And then the other one in front of that is the esophageal temperature probe. It's weird, huh? Isn't it supposed to be behind it? Right? Am I right? So it is behind it, but then it must be just displaced over, right? Huh? But you think the temperature probe is, do you think the temperature probe is in the trachea, or do you think it's in the esophagus? What do you think? Can you use a scope to go in and look? All right, so you'll figure it out. All right, do you need me to not do what I'm doing here on the neck and wait?
If I just move it once, then we'll check with the...
Yeah, yeah, so you want me to wait? Yep, all right, so let's wait. Yeah, I'll at least do the discogram.
Sure.
So we're gonna do a quick discogram, because we do that as part of the procedure at 4-5. Shot, there we go, I can already feel a tear, there it is. Show them the tear and give me an AP. Yeah, that's not the tear, that's the front, but show them the tear in the back. Yeah, right there, yes. So the dye has leaked out through a tear right there, and it's now in the back herniated. This is a grade 4 tear at 4-5. Yeah, we'll do an AP. I need the coker. Let me know if you're okay, doctor. Shot. All right, perfect. Now go back, Jordan, if you don't mind, and show them the tears at 4-5 on both sides. Yeah, that's the right side tear. There's the left. Those are annular tears posteriorly, allowing dye to leak from the center of the disc out through the tear, outside into the back of the disc where the nerve is. So those tears are highly inflamed, and when you get inflammation around the nerve roots, it can actually cause nerve symptoms like pain in the arms, pain in the neck, which this patient has, along with numbness, tingling, even weakness from the inflammation of the nerve root. All right, so we've done our AP and lateral x-rays with the C4-5 disc. What do you think, Doc? Okay. Shot. All right, so guide wire is now in. You can see the tip of the guide wire. I'm going to make my incision. Can I start, or you want me to wait? I'll be infiltrating. We do a little numbing medicine into the skin incision. That way we prevent pain and bleeding with the incision. We have a little epinephrine in there, right, Luis? All right, needle is down. I've injected 1 cc of local. Now, these Deuk laser disc repair surgeries are endoscopic, and they're transdiscal. It means we go from the front where the problem is. It's always best to treat cervical disc herniations from the front. Okay, because the disc is in the front of the spine. So trying to treat disc herniations through the back, shot? Yeah, trying to treat disc herniations through the back of the spine by doing a foraminotomy means you're drilling the bone away in the back of the spine. So Jordan, why don't you show our audience where the herniation is? Pay attention to the white arrow. There's the herniation. Now, where's the spinal cord, Jordan? That's right, it's behind the herniation. Where's the lamina? Go back to the lamina. Show them the lamina, further back to the right. Down a little bit, right there. Now, the surgeons that go through the back of the spine, and I won't mention any names, but there's a lot of them out there, they drill all that bone away back there and try to pick pieces of the disc out around the spinal cord. So you can see the problem. Number one, they can damage the spinal cord if they get too aggressive at removing the herniation from the back. Number two, they can damage the nerve root. They can cause a spinal fluid leak. And most importantly, they can't get to the center of the disc. They can only treat herniations that are way off in the foramen, not anywhere near the center or paracentral, which most patients have center or paracentral. Very few herniations are really lateral. Probably less than 5% of all cervical disc herniations that are symptomatic are far lateral. Therefore, 95% of patients with disc herniations that are symptomatic in the neck cannot have a posterior procedure like a foraminotomy. How are we doing, guys? Any better? No? I don't need the esophageal temperature probe at this point. So take it out. Take them out. Yeah, I see it's kind of bending and coming back. At the vallecula?
His airway is very challenging.
Really? Big guy.
Very.
Yeah, it looks like it's at the vallecula and deflecting and coming back. Show the audience the vallecula. Show them the esophageal temp probe. It's very common. Yeah, right there. Right there where it turns around and goes back. It does like a U-turn. That is what we call the vallecula epiglottica. That's a little piece of tissue that actually closes, and I think that is, right? It's in that area. Okay? All right, so we're just going to remove the probe. We've made our incision. We're going to bring our dilator down. So I'm first going to remove this. You guys ready?
Yeah.
I'm going to remove this needle, and we're going to be left with the guide wire. The guide wire is going to guide this dilator. The dilator, look how skinny that is. It does no damage unless you put it through the esophagus or the carotid artery or the vagus nerve or the jugular vein. So you want to avoid those structures in the neck. And the way you avoid them is by placing the needle properly in the beginning. If you don't place the needle properly, you're going to be in a lot of trouble. Most, like 99.99999% of neurosurgeons don't know how to do this. There's only a few in the world that know how to do this. Literally less than 20 surgeons, spine surgeons in the world know how to do this part of the surgery. Shot? So it is a advanced technique. It is, it's like doing what's called aneurysm surgery. And there's a lot of neurosurgeons, maybe 3,500 in the United States. But of those 3,500, there's probably only 200 that know how to safely clip what's called a basilar artery aneurysm. It's a very difficult aneurysm to treat, and it takes tremendous skill, the right equipment, the right staff in the operating room. Shot. And what I'm getting at is not every spine surgeon can do every spine surgery. That's very important to understand that. So if you're a patient and you need surgery on your spine, what you really want, in my opinion, if I was a patient, I want a surgeon that can do everything. And there are surgeons that can do everything safely and well. You just have to find them. All right, so you can see we've done a 4mm incision. And now we need an AP view to make sure we're in the middle. And like I said, what's in the middle in the front of the spine is something called the anterior longitudinal ligament, the ALL. We abbreviate the ALL. Now the anterior longitudinal ligament runs across the entire front of the spine. And just to the side of it, that's perfect. To the side of the ALL is something called the longus colli muscle. And you have one on the right, one on the left. We want to avoid that. Now look where the spinous process is. Jordan, do you mind showing them the spinous process? Look at the spinous process right at the tip of the dilator. Now that's in the back of the spine. The tip of the dilator is in the front. So they're overlaid. And that's what you want to see. You want to go and enter the disc in the center, which is where the spinous process is. All right, back to a lateral view. I'm going to advance the dilator with my fingers through the ALL and the anterior annulus. Shot. See, now the guide wire is trapped and it's moving backwards. I don't want it to go back anymore. So I'm removing the guide wire. And now I'm going to, everybody's favorite moment when I hammer this thing in. We are now at the back of the disc at C4-5. All right, so I'll give you a lateral view. I don't need the AP view, and I don't want to do an AP view except just to show you guys, but it's unnecessary for me to do the surgery to get an AP view. So I'm not going to expose the patient to the radiation unnecessarily. Shot. Now the other probe, are you leaving it? I guess?
Yeah, because it's kind of wrapped by the tracheal cuff.
So we're okay.
For safety, I'm just going to remove both of them when we get to the
But we're okay keeping it. You're comfortable, yeah. You don't have a leak or anything.
Nope.
All right, so we're passing. And I've made the skin incision really quite small. Shot. So it's giving me a little bit of resistance to push it down. But that's fine. I made the skin incision quite literally 4mm, which is the outer diameter of this tube. Shot? I feel like we're on the disc now. We are. So we're good. So I made the skin incision literally to probably a micron, the same diameter as the tube, which is good. You don't want to make the incision any bigger than you need to. Now I'm going to advance the tube through the disc, but I got to watch the dilator because I don't want to bring the dilator down or up. Sean? Now, some people say, well, are you damaging the disc? No, because what we've done is we've spread the fibers of the anterior annulus and the ALL. We've spread them apart. We haven't cut them. There's no cutting here. It's spreading. That's why dilators are so special in medicine and surgery. They're special because you can spread things without cutting them and damaging them. Shot? So the Deuk laser disc repair is truly a minimally invasive procedure because of the small skin incision, but also the fact we're not cutting anything and damaging anything. So again, you always have to watch your dilator and make sure it doesn't go in too far. Shot? I'm going to bring this in just another millimeter or two, but we're actually in really good position. I think you're off on orbit a little bit. So let's check the orbital position before I go any further. You may be just about a degree. I can't tell if that's better. Go the other way. No, it's worse now. So go back. Yeah, that's good. Perfect, right there. So you can see the tip of the dilator is in the herniation, as a matter of fact. And that's where we want to be. Shot? Yeah, that's perfect. So, all done. And you're pulsing?
Yes, sir.
Well, there you have it. We are starting our first disc. So far, so good. We've got our tube. Can you guys see that? Bring that fluoro back. Chad, are you able to see the tube?
Yes, Doc.
It's literally the size of a coffee straw. All right? We're doing the entire surgery through a tube that big. There's no metal, there's no fusion, there's no artificial disc. Let's show our audience why cervical disc herniations can cause neck pain, headaches, and arm symptoms like tingling, numbness, and weakness in the arms.
3, 2, 1.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Nice job. Welcome back. We're just starting. The metal thing you're seeing is the tube that we're working through. That's the straw. I'm going down the straw. It's not really a straw. There's a herniation right there. I'm going to go grab it out. So the surgery is really a combination of using the laser to free up herniation fragments out of the annulus and clean the annulus scar tissue. Also to grabber. I use a little grabber. And if we get a good size herniation, I'll show it to you. But I just pull out those little pieces with the grabber. So I free up herniated fragments from the annular tear that they're stuck to. Because remember, this is, oh, look at the tear, it's perfect. Can you guys see that? So the white on that side is the annulus. The white on that side is the annulus. It used to be just one continuous piece. But there was a tear from trauma, and now the blue stuff, the jelly, has squeezed through the tear and it's stuck in the tear. And when I put the blue dye in, it stains the nuclear material stuck in the tear. But that's where all of the pain comes from. All right, we're going to clean this tear up. It's called a debridement. You can actually see right there is fibers of the posterior longitudinal ligament up and down. So we want to try to stay above that unless there's a herniation below. So we're literally sitting right on the posterior ligament. That's the fibers of the posterior ligament going up and down, attaching to the back of the vertebral body. And the epidural space and spinal cord are right behind that. Right here is the actual annular tear and herniation. This is exactly what we're here for. So it's absolutely perfect placement of the tube. Good job, Luis.
Oh, thank you.
Good job, Flynn. Aha. All right, beautiful. Right there. Yeah. So there was a complete annular tear from the inside to the outside. And we're going to pull back a little bit in a moment, just like we do in the lumbar. And we'll be able to see. There's a herniation in the foramen, right there. See how it just sits right above that? It's like right there. There's like a space between it, because this is all abnormal right here. It shouldn't be there. That's what we want to zap away. It's sitting right on his nerve. Need to get some more of that. And I'm going to have to come back to the other side as well. The nice thing about cervical endoscopic is you can treat, if you position your tube properly, you can treat both sides of the disc with one incision, one entry point. And you want to have one entry point if you can. That's all herniated disc right there. So this guy definitely needed a surgery. This shouldn't be here. He's got a giant annular tear. He's got a really messed up neck. Now, I could tell you he's also had surgery on his peripheral nerves. Okay? And I've talked to him about this. I've talked to his wife about it. The surgery on the peripheral nerves does not look right to me. He had it done, I think, at the Rothman Institute. I'm not trying to say anything bad about them, but the incision is not in the right place. So to me, it's an example of a surgeon not knowing what they're doing. And you know, whenever you have surgery that isn't done properly, there's a good chance you're not going to be any better or worse. So everyone out there thinks all surgeons are the same. We all do the same thing. Oh, it's like buying a Toyota Corolla 2017. They're all the same, but they're not the same. Surgeons are different. They have different skill levels, different ability. They even have different equipment. Like all this equipment you see me using is not available anywhere else except for a few places. This is all FDA approved. The procedure uses only FDA approved stuff, but you won't find this lasers and these tubes and the camera. You won't find these in every hospital because most hospitals don't have it. They may have an endoscopy system like a camera, but they won't have the spine equipment that we're using. Okay. Yeah, pretty bad shape. This disc was definitely needed to be repaired. Huge tear. We've only seen half of the tear so far. We haven't even gone to the other side yet. I'm in the foramen right there, removing the herniation out of the foramen with the laser. Now I can tell you right now, this surgery cannot be done without a laser. Some people say, oh, but my doctor said you don't need a laser. That's the herniation right there. Yeah, and there's the spinal cord right there, the blue thing. So you want to be really careful not to injure it. I'm very careful with how I do things. I've done a lot of these surgeries now, and I know exactly what to look for and how to avoid problems. That's what an experienced surgeon can provide you. Knowledge about how to stay out of trouble and experience. But there's a lot of older surgeons that aren't so good. So you really got to choose wisely. Be very careful.
Doc, we have a question.
All right, go ahead.
Sierra from Facebook is asking why the patients are awake during the lumbar discogram but not the cervical one.
Yeah, they're awake for the lumbar because my approach is different. I'm coming through the foramen. And the foramen actually has nerves in it. So the last thing in the world we want to do is hit a nerve or damage a nerve, and that's why the patient needs to be awake. If you get too close to a nerve, the patient will say, oh, I have pain down my leg. And at that point, I have to change what I'm doing and move to a different place. So it guides me to help me prevent any kind of injury to the patient. It's about safety. When you do the neck, it's not even close to the same. We're not worried about hitting a nerve going in because there's no nerves along the pathway going in. A good question. This is all stuck down, scarred up herniation in the back of the disc. Any other questions?
Yes, we have a question from Dynamic Disc Designs Corporation on Facebook. Does
Hey,
the blue
Jerome, how are you? It's
And-
my buddy Jerome Pryor.
He's asking, does the blue stain direct your laser treatment location?
Does the blue stain direct my treatment of the patient?
Does the blue stain direct your laser treatment location?
Yeah, the blue stain helps me find herniations. Because when you get in here, it's really hard to tell where the herniations are. And the blue stain makes it possible because it stains the herniation. I want you to all to appreciate, first of all, there's a big herniation just right there at 6 o'clock. I need to go get it because it's keeps sticking its head out. So I'm going to try to go get that right now. But yes, the blue stain is right there. That's the herniation I'm talking about. And you can see that by the yellow color that it's been there for a while, probably a couple of years, and it's already getting scarred up from inflammation on it. Remember, normally a herniation, if it just squeezes out, won't have that golden color. It's pretty rough back here, actually. It's a little worse than I thought it would be, based on the MRI. It's another lesson. You can never trust the MRIs. They don't give you all the information. So you have to really, this is the most accurate thing you can do, is go inside a disc and look around and, you know, see the herniation, see the tear, see the calcification. This is far more sensitive than any MRI. I can actually age most herniations as well. Again, you can see the fibers of the posterior ligament right there running up and down. They have a little bit of blue stain on them because the herniation has been sitting on them, and there's still pieces of herniated nucleus on those fibers. This is the foramen on the patient's, on his left at 4-5. This is the C4-5 foramen, and there's just a lot of herniation in here. So I want to make sure I get it all because it's literally sitting on his nerve. So this is why he's getting his symptoms in his arm. And you can tell it's been there for a while. Just about done with this left side at 4-5. Great questions from our audience. Pulling the tube back a little bit. There's another herniation. Just want to get it out. Sitting around the foramen there. Let's just check. It's looking pretty good. I think we can do a little better. Now what's going to be interesting when we get down to where he had his surgery before, if we can make it down that far, which I expect we will. But he has basically had surgery by another surgeon who did what's called a foramenotomy through the front. And this guy has been doing these procedures for many, many years out of Pittsburgh, Dr. Joe. I personally don't agree with his technique. I think maybe 30 years ago it was good, but the transdiscal technique is far better, what I'm doing, and the results are far, far, far better, in my opinion. So, patient said he had Dr. Joe's surgery. He got better for 2 months, and then he had horrible pain afterwards. So the reason for that is Dr. Joe's surgery removes bone in the spine. When you start removing bone and joints, like the facet joints, what you're doing is, yeah, you're making more room for the nerve temporarily, but then it creates instability, and instability causes the bones and ligaments, the joints, to get bigger over time, hypertrophy. And that hypertrophy then causes new worsening symptoms. So with the Deuk laser disc repair, we're only repairing the disc itself. I don't remove bone or joints or ligaments. I'm just taking out the herniation and cleaning the annular tear. Now look at that. That's actually a normal disc. Some normal disc there. So this, at this level, most of the problem is on the left side. Let's flip it. There's still more herniated fragments coming out. Now, some of these fragments are white, and the reason they're white and not blue is because to turn blue, the dye itself has to make contact with the nuclear material. Excuse me. Anyway, the nuclear material, remember, it promotes inflammation. Inflammation promotes scarring in turn. So what's happening is these patients get a herniated nucleus material, which then promotes inflammation back at the annulus, which then coats the herniation with scar tissue, which then blocks the penetration of the dye. So some herniations are going to be white, the older ones, okay? And there's nothing you can do about it. All right, let's go back to the other side. Yeah, it's fine, thank you. A lot of herniations are bilateral in the neck. Some are unilateral. In this case, that's normal. I don't think I want to mess with it. I just got to verify that. Those are all fibers of the posterior ligament. Just want to make sure. It could be scar tissue and it's tricking me. So I want to try to get a good look. See, to me, that looks pretty good. Yeah, I think most of the problem at this level was this side. All right, we're done here.
All right. Stop off, please. Lights on, please.
So I'm going to put a little antiseptic. We've never had an infection with the Deuk laser disc repair. Over 1,400 surgeries. I need the dilator. And largely because there's no bleeding, the incision is very small. We use very good sterile technique. And there's no implants. Those are all factors that reduce the chance of infection. So when it comes to spinal surgery, if you're putting in metal, whether it's an artificial disc or a fusion, oh, we're done with the irrigation. If you're putting metal in somebody, it's called a foreign body, and that has a much higher chance of getting infected than no metal. So these surgeries, we don't put any metal. Careful with that. Also, the incision is tiny, as you can see, so less chance of bacteria getting in. And of course, we have a state-of-the-art center with the most advanced sterilization equipment in the world. We actually have 2 units that are, each one by itself is extremely advanced. So we've got great sterilization technique and equipment. We've got small incision, we've got no implants. We've got a short operative time, and we have minimal to no bleeding. All those things reduce the chance of infection. Plus, we got the best anesthesiologist in the world. Right? All right. So now I'm going to move up to C3-4. Actually, I may try to do 5-6. I may try to do 5-6 first. I think I'm going to do that. So I have to take the tube out, but keep the dilator stable. Shot. I don't want it going in any further. I don't want it coming out. So I'm taking out the tube right over the dilator. Okay. I'll give it to Luis. Watch the laser fiber. I don't want it breaking. It's sticking out. I wouldn't let it stick out like that. Huh? Yeah, so guys and gals, we're going to go for the next disc down, which is a hard one. So I'll need to visualize the next disc down. So I'll need a little inline, I'll need a little shoulder pull, I'll need good fluoroscopy, and we'll be good. I don't know. Let's see what we do without your shoulder pull, Luis.
All right.
Let's just do her shoulder pull.
Just don't, yeah, you grab it.
All right, so
Don't pull too hard, right?
shot.
Go, go, go. Yeah.
Yeah,
Yeah.
that looks pretty good. I think I can get it with that. So let's just, I'm coming out, shot. So this is the hardest part of the surgery, in my opinion, is feeling when the tip of the dilator is out of the disc, and then keeping it from lifting, shot. Keeping it from lifting, there we go, I'm out. So I'm right outside the disc, I'm right on the tip, and I want to make sure that I haven't slid left or right, because the soft tissues are going to push me. So let me, hold on, let me just check. And it's really a feel thing, folks. And if I can't slide properly, I'm not going to go for it. I'm just going to do another entry point through the skin. Shot. All right, so I've slid a little bit to my side. That's because all the muscles in this neck are pushing me. Shot. I want to plant the tip right in the center and then move it down. It's really hard to get down. At the same time, I don't want to radiate my hands. Hold on. It's moving. I think I'm going to have to go north. I don't think I can get south. So let's just go back to a lateral. Quick lateral. 2, 3, 4, 5. I'm sitting on 5. You agree? 2, 3, 4, 5. All right. I'm going to go up. Shot. Shot. Give me an AP. So I've cleared the 4-5 disc that I just fixed. Now I need to make sure I'm near the middle. If I'm not, I have to correct. Shot. Yeah, I'm near the middle. Good. So let's go back to a lateral. So I'm happy with my front back view. I'm near the middle. I'll correct it before I go in the disc, make it more perfect, but I can feel the ALL. I'm sliding along it nicely so far. Yep, there we go. Shot. So last week I did a surgery which was a 4-level through 1 incision. And there's no way I can do that with this patient. It's impossible. I could feel the soft tissues not letting me. But the other guy I could. So we got lucky. All right, give me a good AP. That looks pretty good. Yeah, lateral. Yeah, so we're doing everything we can to do it through 1 incision, but it's not going to happen. And I'm not going to compromise safety. I need a little inline at this point, just a little, so I get some tension on the anterior. Yeah, that's nice. Shot. That's good. I'm going to go a little more north. Shot. That looks good to me. We're going to go through the anterior longitudinal ligament. Let's get a Coker AP. Any questions from our audience?
Yes, Austin from Facebook is asking.
That it?
I'm only
Shot.
25 and it's showing bilateral sacroiliac degenerative disc disease, and I've been suffering with sciatic foot pain. Is that surgery an option?
Yes. So Austin from Facebook, thanks for calling in and asking. Yes, anybody at any age is a candidate for the Deuk laser disc repair surgery because it's so gentle and minimally invasive. And I can tell you right now, if you've got a herniated disc at L5-S1, you know, degenerative disc disease at L5-S1, that's not going to go away on its own. And you're going to have pain the rest of your life. You're 25, you'll probably live hopefully to 95 at least, shot, and maybe longer. And then you're talking about a lifetime of pain that's going to be debilitating. And the thing about pain from a herniated disc is that the more active you are, the more you do, the more it hurts. So the reason for that is every time you're active, you're squeezing out a little more, a little bit more of that, there's the tear. You're squeezing out a little more jelly in through the tear, and that causes more inflammation. AP? So you can see the tear. Why don't you show them the tear real quick, and then let's go with an AP. So the best surgery in the world for a herniated disc, that's the tear at C3-4. The best surgery in the world for a herniated disc that's causing pain is this surgery you're watching right now, but on the back. And we have literally 500 surgeries recorded and online for you to watch. All right. Let's go to lateral view. You can see the patient has some scoliosis as well. So far, things are going well for him. Shot. So I'm going to advance the dilator a little further. Shot. To the back of this disc. Shot. And then you can see the herniation. Shot. Right past the tip there is the herniation. Shot. Yeah, so I'm literally touching the herniation right now. I'm going to bring my tube back down over the dilator. I want to make sure the dilator doesn't get pushed backward. Shot. Because sometimes discs are under high pressure and they'll literally push the dilator out. More so in the lumbar than the cervical. Shot. But it can happen with any recently herniated disc because those recent herniations cause acute inflammation. The inflammation gets really bad and it just causes so much swelling. And it's the swelling that in the disc that causes some pain, but also it pushes the tube out once we get it in. Shot. Look at that. So you see that it literally just pushed it back. I don't want that happening. Shot. Shot. Yeah, I want to keep my dilator in position. Shot. All right, so I'm just going to advance. Shot, and then I'll readjust the positioning. Shot. All right, so that's good. We'll put the dilator back in. Shot. Great question so far from the audience. Shot. All right, so now I don't want to trap the dilator. Shot. It looks like it's just jiggling around. Shot. When I say shot, it means take a picture. It doesn't mean do a shot. We're not doing jello shots here or cement mixers. Shot. Or actually, shot means picture. Don't ask me why. That's just kind of how neurosurgeons say it. And that's the way it was said when I did my training. And 7 years of learning something one way kind of sticks with you. That said, Dr. Patel doesn't say shot. He always says picture. Picture. So when I think of a picture, I think of a color picture, right? A camera picture, not a X-ray picture. But to each their own. So my way of saying take an X-ray picture is shot, in case you're wondering. Any more questions from our audience? All right, we're getting started on disc number 2, which is the C3-4 disc. C3-4. We've already done 4-5, now we're doing 3-4. Of all the discs in this neck, if you ask my opinion based on the x-rays and MRI, 3-4 and 4-5 are 2 discs that are best preserved, like very well preserved, compared to the other ones, 5-6 and 6-7. Which are more degenerated. There's a big tear here. You can see the nuclear material stained. It's right there. I'm going to go grab that out because it's a good sized piece of herniation.
Dr. Deuk, we have a question.
Sure.
Michael from YouTube is asking, I have a consultation next week with you in regards to a herniated disc at T7, T8. That disc turned into a bone spur compressing my cord. Is your procedure an option for me?
Yeah, great question. So a thoracic disc herniation can definitely be treated with Deuk laser disc repair. But if it's truly a bone, if it's truly, so there's a difference between a bone spur and a calcified disc. Calcified disc means the entire herniation is rock hard. That is not the kind of surgery that that's not the kind of problem I can fix with the surgery. If you have a if you have a bone spur, that can definitely be taken care of with the laser. We remove bone spurs all the time. But a calcified herniation and a bone spur are different things. So what you're telling me is you have a bone spur. Now, the only way you're ever going to know if you have a calcified herniation is with a CAT scan. So if you have a CAT scan, and if you don't, you need one. You want to look and see on the CAT scan, is it completely white, which means it's totally calcified, in which case I can't do anything with this laser surgery. You're going to need to have it drilled out. And mostly because the laser trajectory is not towards the center, it's towards the sides. So once again, you can see here the big annular tear, pieces of herniation right there, and it's really kind of stuck in here. I'm not sure if there's just some material along the wall, but I'm having a hard time sliding it in and out. That's better. A little bit better. I don't think this is a bent tube, right? No. Yeah, so here's a piece of herniation right here. And once again, you can see fibers from the posterior longitudinal ligament, PLL, back there. And that's where just behind that's where the spinal cord is. You can actually see a little bit of herniation right where the laser is going through. So I just kind of clean that up. And again here, and it looks like a big tear there in the PLL. So that may actually be dura right there. That's what I'm thinking. So we want to avoid injuring that at all costs. But people ask me, how close are you to the spinal cord? Well, right there. That is the spinal cord. So as a oh, look at that herniation. Oh, look at that. You see that thing? Oh, tell me that isn't cool. Did you see it? It just came right out. See, that's what we live for. Now, I coined those. Yeah. I call those, I'm the first person to call those something because I'm the first person to name it, but it's called a reverse herniation. Put the light on and let's show everybody this thing that I just pulled out. It's good size. It's about, can you see it with that, or white? White may be better, I don't know. Can you see this? It's probably about 2 by 2 millimeters. Can you see it or not?
The blue is better.
Blue is better. All right, Luis had it right. How's that?
We can see it.
Perfect. So that's what I do. I release the herniations and grab them out. I have a feeling there's another piece in there because I think the herniation may be bigger than that. It may have come out, it's going to come out in 2 pieces perhaps. I have to go back and look. But are you sure? Yeah. I'm just putting the scope back down. Have to turn on the irrigation. So anyway, who thought that was cool? I thought that was super cool. Again, it's just sticky, you know, it's really sticky. There it is. I told you, there's still herniation down there. So I didn't get it all. I could tell when it came out, it wasn't big enough to be the whole thing. So it must have broken in half. All right, let's show the audience how the Deuk laser disc repair works. Yeah. Let's do the video that shows them how the Deuk laser disc repair works.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. the laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, very good. Hope you guys had a chance to watch the video and see what it is that we do with the laser surgery. This is called the Deuk laser disc repair. And once again, I pioneered this technique about 16 years ago. We published it for the first time in 2012 in the National Library of Medicine. So we did a submission for a peer review in Surgical Neurology International. That was the journal that I chose. There's literally thousands of journals you could publish in, but the one I chose was because it was free, so the public could access it and read it without paying money, because I like information to be available. And so if you look it up on PubMed, you can actually see, type in PubMed, P-U-B-M-E-D, and then Deuk laser disc repair, and you will see some of our publications in the National Library of Medicine. This surgery has also been featured now in a new textbook that was just published this year on the most advanced endoscopic spine surgeries in the world. And so the Deuk laser disc repair was mentioned in chapter 1, the first chapter. So, all right. Oh, look at all that. There's just so much herniation back here. And I'm going to try to float out as much of these pieces as I can. See, that's helping. So that's what it is. I think the cable is getting pulled and torquing it. Yeah. You know how you're lifting it right now?
Yeah, that helps.
Yeah.
Okay.
Oh, come on. Get out of there. Oh, well. It's just aggravating. There we go. Great job, Jordan. It's weird. I don't know. Jeez, non-stop herniations. It's so funny because you really can't see this on the MRI. I mean, you see a small amount, but you don't appreciate just how much damage was done to the disc. There was a name for this. I didn't name it, but it was named by another doctor years ago, and it's called internal disc disruption. Internal disc disruption, IDD. Just be careful not to get anything, you know. And, you know, most people don't really believe in IDD, but I do, and I've seen it with endoscopic surgery. It's 100% real. You can do an MRI and not see it, but then you get inside the disc and you see all this herniated material and just complete catastrophe of the disc itself, and you realize, wow, you know, this is not seen on the MRI. It's not appreciated on the MRI because it's inside the disc, and MRIs really can't see the inside of the disc that well. You can see the disc, but you can't appreciate all the internal disruption, all the damage that's gone on. It's like a black box for the MRI. It just can't see inside it. Yeah, this is pulling. You guys got to make sure, don't give us any more. That's not sterile, but you guys got to make sure we have adequate length before you get started, okay? All right, so this is the foramen again. This is, I'm not sure which side. It's going to be his left foramen. this patient actually has symptoms in both hands, a little bit worse on the right side. And I suspect that's from Dr. Joe's surgery, because it's pretty messed up where Joe did his surgery. And I'm not suggesting at all that Dr. Joe is a bad surgeon. I'm just saying, I have to grab that out. I'm just saying that whenever you start drilling away bones, joints, ligaments, tendons in the spine, it causes instability. Okay, instability means that the spine moves, it deforms, we call it, changes shape, like at the joints, in such a way that it creates pain or neurological compromise. And that's what's happening with this patient. And that's partially at C6-C7 because he's had surgery there before. All right. This disc in particular, though, is just a giant annular tear and multiple herniations. So this is not the one that he's had prior surgery on. But I don't want to confuse everybody. Please. It's so difficult to get in and out of this tube. It's really... That's the dura down there. And again, more herniated disc. So this once again is C3-C4. If you look at it on the MRI, it doesn't look too bad, but it's definitely abnormal. But you don't get a sense of how abnormal it really is until you go inside the disc, like I'm doing now, and see just how much destruction there is. So I know Jerome can appreciate this. Chiropractors always are talking about internal disc disruption and how it can cause so much pain and patient dysfunction. It's true. I believe it. I agree. But, you know, good luck getting a neurosurgeon to agree. They don't. They just don't know anything about pain. They really don't. At least not from a degenerated spine. So that is the dura, by the way. All right, right down there. Spinal cord. And these herniations, you can see, are just sitting right on top of the spinal cord. And this patient has numbness and tingling in his arms and hands. And I said, you know, I think we need to fix these discs because they're definitely contributing. I just don't know if they're causing all of it. And he understands that there's no way to know it's causing all of it or not, because he does have other issues on the nerve test. He's got carpal tunnel and ulnar nerve that he's already had surgery for, that really didn't work very well, in my opinion. All right, if there's no questions, let's go ahead and run another video. Let's do a comparison of what this patient could have had, a fusion called an ACDF. We're almost done with this disc. I'm going to be coming out in just a minute. You can see this is the neuroforamen, by the way, where the nerve is, and that's a herniation just sitting right on the nerve right there. The nerve is literally right there, and the herniation is right here. So I am literally operating just millimeter away from the nerve. And but I can see it clearly, and I'm making sure I don't do anything I'm not supposed to do.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
1.
Shot. All right, so we're just getting ready to get started on the next disc, which is going to be 5-6. And shot. Let's get an AP. Quick AP. Quick shot. I want to be in the midline. 2, 3. That looks good. Back to a lateral. A little off to the other side, so I'm over pushing, but that's good. I need a lateral. Perfect. That looks pretty good, right? Shot. It's like we're right there. I am having trouble seeing that disc space now. Or feeling it, for that matter. Shot. 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 Interesting. Shot. Give me an AP quick. Just stay where you guys are. I'm almost done. Quick, quick. Yeah, we're in the middle. Get back to a lateral. There's a bone spur there. Right in the front. Shot. And it's blocking me from getting in. Shot. I'm gonna have to go around it if I can. No. There it is. There it is. Shot.
Okay, good.
Phew. Give me an AP. Wait. Let me get a coker. You guys relax for a second. Just relax for a second. Phew. That was not easy. Shot. All right, that's perfect. Look at that center line. All right, lateral. So we're gonna, actually, you know what? Stay where you are. I'm gonna do a discogram. Let's just do this as the AP discogram. Give me a second. Coker, shot. Wait. Coker, then shot. Shot. Perfect. You can see the tears on both sides once again. This patient must have really traumatized their spine to have 4 discs, all with big tears and herniations galore. All right, at this point, I'm happy. Well, let's see. Let's get a shoulder pull and an inline traction pull. And let's do one more x-ray. I'll get this side. 1, 2, 3. Perfect. Look at that. Nice. 2, 3, 4, 5, 6. It gives me aspiration and hope for 6, 7. Right, Luis? All right, shot. All right, perfect. You did good there, Jord. Hold on. Who's calling? What is it? Oh, yeah. Yeah, not yet. I mean, yes, you can for a second while I numb up, but I'll need you back. Yeah, for a second. I don't want you to windsurf down there. So I'm giving a little bit of numbing medicine again with some epinephrine. We're going to have to do a second incision. Sometimes I can get the disc done with one incision, but this patient anatomy will not allow it. I tried, but it's not working. 4 millimeters. The whole surgery is done with this one 4 millimeter incision. Well, 2 4 millimeter incisions. Okay, so we've shown you videos on what we're doing. Why don't we run the Deuk laser disc repair one more time so they understand what the surgery is? Shot? Let's see if I can see this. I can see this without a pull, so we're good. Are you still pulling? No, you don't need to right now.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, we are getting ready to enter C5-6. Stay where you are, mallet. Shot. Shot. Oh yeah. And shot. Felt like it went in. Or I slid. I'm aiming. I want to aim a little down. Shot. That's better. Shot. Take that. Just want to get it started through the annulus. Take. And this is a hard anterior annulus because there was a bone spur, calcium deposit in the front. Shot. Yeah, I can actually see the tip. That's nice. Shot. And I'm going to go just to the back. Shot. A little more. Shot. Oh, good job, Jord. Now, Jordan, I'm going to guess. We've been working together for how many years? 6 years? 5, 6 years? 4 years. 4 years. Seems longer. I'm going to guess that your parents liked rivers or they liked basketball players. Nice. That's cool. To be named after a legend? Oh, no way. Mike. I didn't know your middle name was Michael. Shot? That's awesome. You ought to get free Jordan sneakers for the rest of your life just for your name. Seriously. Nike, if you're out there listening, we've got our X-ray tech here. He deserves it. He's a great guy. Send him some Air Jordans. You want to know? When I was in, I want to say high school or college. It was like 1986 or 87 when the Jordans first came out. I actually got a pair of the original Jordans because I was a basketball player. I was on varsity basketball and I took basketball like that was, I love basketball. I was crazy about basketball and soccer. Little inline shot. I had the original Jordans. And like a lot of people had them. But now, if I had those, I could sell them. I could probably retire. Shot. If only I knew, right? I could have a private jet. Shot. Could fund my kid in racing. Shot. All right. You're a brave man, Luis, putting those fingertips there. I think that's good. I could feel it. We're docked. So, for those of you who have been watching the whole surgery, congratulations. We made one incision here, and that's where we did the C3-C4 disc. And then the second one is here. And we're doing 5-6 now. And the reason I had to do a second incision, I could not move the dilator along the spine southward. There's something blocking it. So I wasn't going to tear it. Tearing things in the neck is not a good option. We are ready. We're going to get started here on our third disc, and then we've got one more after this. We'll be done. So far, we've had some great questions. Any more questions from the audience?
Yes, we have a question from Sierra on Facebook. How active can you be after the Deuk laser disc repair?
How active can you be after the Deuk laser disc repair? That's from Siri?
Sierra on Facebook.
Sierra. Okay, thank you for asking, Sierra. So you want to let the disc heal completely. Once the disc has healed completely, you can do whatever you want. There's no restrictions. I would warn you, though, if you do a lot of contact sports where you hurt your neck. Excuse me. God, what do we got? Pollen in here? Or am I just getting allergic to work? You know, you want to be careful with your neck. You can go back to doing pretty much everything. There's a few activities that are going to really put you at higher risk for re-injuring your discs. And that's going to be things like, you know, powerlifting, like jujitsu, any kind of grappling, boxing. But, you know, aside from those kind of things, you can do everything. I tell my patients, once you're healed, you can go parachuting, you know, if you want to. Do whatever you want. No restrictions. There's a herniation right there. And it's the truth. It takes the disc a year to fully heal because, to be quite honest with you, the disc doesn't heal fast. It heals slow. And the reason it heals very slow is it doesn't have much blood flow. It doesn't get a good blood supply. So for things to heal quickly, they need lots and lots of blood supply. And the reason the disc doesn't have blood supply is that's just the way God made it. There's the spinal cord down there. Again, you can see the herniations right on top of it. There's just a huge hole there. That hole shouldn't be there. All this stuff right here shouldn't be there, but it is. So it's amazing. You look at the MRI, and honestly, you would never guess it was this bad, ever. But the patient's a big, strong guy, and he's not a baby. So when he's complaining, you know that it's real. And this is where most doctors fail their patients. They don't really pay attention or believe their patients. A lot of doctors say, oh, they're faking it, you know. You don't need treatment, or go see pain management, or go see a psychiatrist. It's all in your head. And it's the worst thing the doctor can do to the patient is to basically deny the validity of their complaints. And the reason the doctors do that is they're not mean doctors. They just don't understand the disease. They don't understand where the pain's coming from. So they look at an MRI and the red is normal or red is, you know, disc bulge, and they're like, well, that couldn't possibly cause that much pain. Well, it does. Disc bulges can cause horrible pain. Oh, look at the herniation, just came out of the foramen. Beautiful. So you can see, definitely, this patient needed these things done. So let's see how many more herniations there are in there. Once again, this is the C5-6 disc. For some reason, I can move the tube a little better now, Luis. I don't know why, but
Well, I changed it.
yeah. Oh, you changed it.
I changed it.
Ah, so the tube may be bent.
Okay, so I need to check.
Does that make sense?
Make sense?
Yeah, I think the tube is bent.
Okay.
Yeah. I didn't realize you changed it, so yeah, I forgot. By the way, that's a bone spur right there. One right there. Goodbye, bone spur. So for those of you wondering, the bone spurs go away with the laser 100%. But I only take away the ones that need to go away. So there's a lot of bone spurs that I leave because just trying to get every bone spur, you're going to end up messing the patient up. Going to hurt something. And I don't want to hurt anything. So that foramen is clean. I'm going to go to the other side now. Again, there's no fusion here. There's no hospital stay. This surgery is outpatient. This patient will go home an hour after the surgery. And I've done 1,400 or, maybe more, almost 1,450 probably by now. I've stopped really counting of these surgeries endoscopically in my 26 years, which really I've only been doing it 16 years. So 26 years of neurosurgery, spine surgery, and 16 years of endoscopic surgery. And the other 10 years, all I was doing was fusions. And fusions work great, by the way. They work really good when I do them. And a lot of good surgeons do good fusions, so they get good results. But why have a fusion if you don't need it? Why have a metal plate put in your neck, trouble swallowing, narcotics, missing life and work and everything else you have to miss? It's unnecessary. So that's what these videos are about. We're trying to teach the world you don't have to have fusions anymore or artificial discs. Artificial discs are just as bad. Look online and look at all the problems that people have from artificial disc surgery. They end up having to get fusions. There's a huge disc herniation. This is his right arm. That thing is pushing on the nerve pretty bad. That thing is just stuffed in that foramen. So he's going to feel a lot better when I get done with this. All right, just about done. This disc is going quicker than I thought. Oh, there's a big one. Look at that thing. Get out of there. Wow, that's a big, huge, scarred up and calcifying herniation. Oh, fuck me. Move that. You gotta move that away from my hand. I don't know if I got it. Alright, let's see what we got. Hopefully I didn't. Alright, still got the tip. Alright, so more herniation on the right side. Big. Look at that, sitting in the foramen. Look at that. It is huge. That is like the Death Star. No. An Imperial, what is it called? Come on, the big ship. The Imperial Star Destroyer or something. Oh my God, do we not have any Star Wars fans in here? Are you kidding me? Fire everybody. Anyway, it looks like a giant thing just sitting there in the foramen. And it is. That is a giant herniation. So that's not it right there, but that's definitely a herniation too. I'm gonna float that one out if I can. But the next one I'm about to go attack is the biggie. And it's on the right side, so that's where his worst arm pain is. Look at it, just sitting right on the nerve. Wait, when this comes out, you'll see what I'm talking about. That the nerve is just under there. Come on. The nerve is just underneath it. Get out of there. All right. Now this patient, again, I told you is from Philadelphia. I think Pittsburgh. If I'm not mistaken. Is that right? Oh, New Jersey. Oh, sorry. He went to Pittsburgh for surgery. Right. Before me. But he told me if he knew about me, he would have come to me first instead of the other surgeon. That's important. All right. Actually, this looks like this may have been the disc. It may have been one of the discs he had surgery on, but I'm not sure because this looks like a lot of scar tissue in here, either from bad inflammation or bad surgery. Oh my God, look at that. Well, we're getting the word out. By the way, if you are interested in learning more about what Deuk Spine does or has to offer, download our app. It's free onto your phone. We have an Apple version and an Android version. And we created the app to help people learn more about spine stuff, like what kind of problems affect the spine and what are the treatments available. We also have a very, very, sorry, I'm just enjoying removing this. Look at that, herniation. And again, right side, this is all right arm. Oh, look at that thing. Ho-ho! That was literally crushing his nerve. So we freed it. I just wonder how much more is there. Anyway, the YouTube channel, Deuk Spine Institute YouTube channel has got like literally thousands of videos. We have surgeries you could watch, the whole surgery in high definition. You have fusion surgeries, laser surgeries. You have carpal tunnel syndrome surgery if you want to watch. We got a whole bunch of spine surgery out there, you know, free, open to the public, just to teach you all. It's like a library of complex and minimally invasive spine surgery. It's all free at our YouTube channel. The app also has a lot of those, and you can also get a free MRI review through the app if you want. The app is, oh, look at that. The app is Deuk Spine Institute app. It's free. Everything free, free, free. You know, we try to do as much free as we can. Surgery can't be free, but I got to pull that out. You know, a lot of the services we offer to people are free because we want them to learn and understand that their pain can be cured as long as we can figure out where it's coming from. And, you know, we can figure out where 99% of people's pain comes from as long as we're given the opportunity to do so. But sometimes people get treatment for one source of pain, it goes away, but then they have another source of pain that has to be treated. And a lot of times, I'll be honest with you, people come to the clinic and they may have disc pain, but then we do a disc treatment and then they end up having facet pain afterwards. So they probably had the facet problem before, but now that we've fixed the disc problem, now they're feeling the facet pain. So we have a case of that, as a matter of fact, on one of our patients. We've just confirmed they have facet pain through a medial branch block. The point is as long as we know the source of pain, we can treat it. You know how many cases of fibromyalgia I've seen in the last 50,000 back pain patients? Take my last 50,000 patients I've seen with chronic back pain. How many had fibromyalgia, true fibromyalgia? Anybody know? How's our irrigation? I'm having trouble floating these things up. Zero. Wow, that is a bold statement, but you are correct. Zero. So what is fibromyalgia mostly? I'm sorry, please don't hate me for saying this, but most people's diagnosis of fibromyalgia is wrong. They don't have fibromyalgia. They have facet pain or disc pain, but their doctors can't figure it out, so they just call it fibromyalgia. Well, guess what? Fibromyalgia is not treatable. It's not curable. You just take pills or other things for the rest of your life, and you live in pain every day. It's horrible. So there is cases of fibromyalgia. I'm not denying the disease exists, but I'm telling you, I'm telling you, most people with a diagnosis of fibromyalgia, they don't actually have it. They have facet pain or disc pain. So what we offer is a free MRI review for people who want to know, why am I having pain and is it fixable? And that's why we do all these videos, is to teach people that untreatable conditions really rarely exist. Everything is treatable and fixable. There's a few things that are not fixable. Of course, fibromyalgia is one of them. But again, I think it's vastly overdiagnosed, misdiagnosed, incorrectly. And the problem with that is it takes away people's hope. Because if you believe you have fibromyalgia when you really don't, you're not going to get treatment and you're going to end up living in pain your whole life. And that's what I don't want. I don't want people to live in pain unless they want to live in pain. There are people that want to live in pain, believe it or not. I say that not facetiously, but it's true. I've encountered some people, especially on the internet, that refuse to believe, despite overwhelming preponderance of evidence, that back pain and neck pain can be cured with the right treatment. They fight it, and they want to be in pain. And the only reason I think they want to be in pain is that they're so used to getting coddled and attention. It's almost like a child having not a temper tantrum for attention, but something similar. Why am I talking about this right now? Because it's true. And, I want people to understand that the vast majority of spine pain, back and neck pain, can be cured. It just requires the right diagnosis and the right treatment. And most people have more than one cause. They have 2 or 3. So I'm still working on this right foramen. Look at all the herniation in here. It's unbelievable. And this was the arm that bothered him the most. So I've released them out of the foramen. Each one of these is its own herniation, by the way. So think about how many herniations have we seen right now at this disc at C5-6 on the right side. We've seen at least 15, right? So that means he's had 15 episodes where he's re-herniated 15 times. Let's say there are 30. That means he's herniated 30 times. Each herniation you see is its own episode, its own chapter in the story of his pain. Same thing for everybody. Every herniation you have is another episode. So that's how it works. The nucleus herniates out multiple times throughout life. The sooner you get your disc fixed, the sooner it stops happening. People say to me, can you put more jelly back in the disc? No, you can't. But what you can do is stop the herniations from happening. And the way you do that is not by being inactive, just sitting on the couch your whole life, but it's by getting the disc fixed with the Deuk laser disc repair. You're kidding me. How's my irrigation pressure? These little things are not floating out. They're just sitting here, falling back. And it's very aggravating because it's kind of a waste of time. Are you sure you can't get more pressure? Huh? I don't know. I'm just asking. Yeah. All right. I don't know about that. Now they're floating up, so yeah. Goodbye. Don't let the door hit you on the back. Right, Luis? Just about done here. So far, any questions from the audience? Look at that herniation there. Huh?
We have a question from Sir on Facebook. What's facet pain?
Oh, what's facet pain? Great question. So the facet joints are small joints in the back of the discs, and look them up online. I can't really show you right now what they are, but Google it, and you'll see that they're little joints in the back of the spine. There's one on the right, one on the left, and for every disc there's a facet joint. 2 facet joints, sorry. Another bone spur. Goodbye. Bone spurs, we don't like you. You're not welcome here anymore. Right, Luis?
Yeah.
Facet joints get arthritis in them. And when they get the arthritis, they start to hurt. They cause pain. So fixing the disc like I'm doing right now won't fix the facet joint. Only treatment on the facet joint will fix the facet joint. See that bone spur? Just goodbye. There's the nerve in the foramen right there. You see that? That literally is the nerve right there. We're at C5-6, so that's the C6 nerve root. And I'm just opening up the foramen here by removing the scarred up herniation. So just about done. That's on his left. We've already done the right for the most part. My feet are starting to get wet. Trying to figure out why. Yeah. All right. Let's go back to the right side. I need a little more laser length. The 12 o'clock position, by the way, is the laser fiber. It's glass. And it literally brings laser energy from a machine in the operating room. A holmium YAG laser. Somebody asked me the other day, is it a CO2 laser? No, it's a holmium YAG laser. Just about done, Doc. And then I've got one more to go. If I can reach it. This is really bad on the right side here.
We have a question from Santosh on Facebook. What are your laser settings?
Hi, Santosh. The laser settings for cervical are 2 joules, 10 hertz. 20 watts. 2 joules, 10 hertz. Somebody asked me a week ago how much energy you typically give to a cervical disc. And I always say I don't discriminate, but we guesstimate around 20, 20,000. All right, I think I'm just about done here. I've gotten all the herniation except for maybe 1 or 2, and we're just about finished at C5-6. Now my laser settings are 2 and 10 for this 1/2 millimeter fiber, and that's with my machine. So I have a, what do we have here at Deuk Spine? Luminous? 100 watt. A luminous 100 watt. So if you have a luminous 100 watt, then you would want to use probably my settings. Oh, this drives me crazy. But if you have a different kind of laser, you may want to try something different. Why are we getting water all over the floor? I mean, literally, you have a lake here. Where is it coming from?
Maybe between the patient. Yeah.
I mean, how could it possibly be coming down? I don't understand that.
Shooting down this way. Maybe. The pressure.
I think this needs to be in the down position. All right.
Stop on, please.
Just about done here. Don't move. See if you can figure it out.
This one?
A lot of scar tissue right here in this foramen. I don't know if he had the surgery at this level, but it looks like there was surgery done. So. Oh yeah, 5, 6, 6, 7. So it is this level. Yeah, you could tell. Yeah. All right, we're done here.
Lights on, please. Stop off, please.
Yeah, so that's where he had his prior surgery. But you can see all the junk in there that we got rid of. On the right side, that's because the surgery he had was destructive and caused instability, and that instability then caused a all the bone and ligaments to thicken and fill up the foramen with junk, all arthritic junk. We call it arthritic junk. That's not the technical term, obviously, but to help you all understand that. So that surgery Dr. Joe did destroyed a perfectly good joint and caused a recurrence of symptoms after 2 months. So the Deuk laser disc repair is different. We don't destroy joints. We preserve them. Huh? want to try. Everybody ready for 6-7? Now this is like if you were a mountain climber. This next disc is kind of like summiting K2, right? You don't know if you can get it. It all depends on the weather, your guide, your health, all that good stuff. But if you get it, oh, the joy. So, we're going to try, but we need everybody to be perfect in their jobs. Not yet, not yet. Let's just start with you with inline traction and little extension. And then Jordan, you want to optimize your floral position? 2, 3, 4, 5, 6. Yeah. And then I'll give a little shoulder pull, nice and gentle, not too hard. And then Luis will do his job, and then Jordan will fire. There we go. Now we got to improve that. I need some of the lights down. I need these lights off, please. Can't really see. That's better. Oh, that's better. I think I can see it. All right, here we go. Everybody hang on. Here we go for the big ride. Shot. And we're out. Let's see if I can slide down. I'm sliding. Shot. All right, I got to get an AP. Just give me a quick AP in a second. 1, 2, and 3. Don't move your arm. All right, good. We're good. Need to be a little more towards Luis. And give me that pull and give me that shot. Shot. Feeling a bone spur. You guys are giving me a great shot. Shot. We're almost there. A little more. Shot. Too low. Shot. Everyone hang in there. We're almost there. Shot. I need an AP now. Right now. And it's a quick AP. Everyone hold. We're almost there. Shot. Lateral. Perfect. That's bone. It's got a huge. I need to see better. I need to see better. Oh yeah. Oh, we got it. I think we got it. Shot. Shot. Is that it right there? Shot. Shot. Pretty collapsed. All right, everyone relax for a minute. We're good. We regroup, but so far we're in. Just show us a little more of C2 so we can 100%. Here, I'll do the shoulder pull. Go. 2, 3, 4, 5, 6, 7. All right. Now I'll do a discogram. Great job, team. So we entered 6, 7 in the middle. In the dark. Hold on. I got it. All right. Shot. Give me an AP. I don't know if we're going to get much dye out. I think we're fine. Looks good. All right, let's go back to a lateral view and get this whole thing, contraption in position. I'll need a little shoulder pull, inline traction. Jordan, I need you to do your best. Don't pull the whole patient out, guys. Shot. Oh, that's better. Shot. 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 That's pretty good, huh? Right? Right there, shot. All right, let's see what we can do. Stay there and let's do just a quick, bring the tube down. So far we've fixed 3 out of these 4 discs. The last one I didn't give a lot of hope to achieving, but we're there. So it's pretty collapsed though, that's one issue. We're going to do our best here, as we always do at Deuk Spine. I got it. Shot. Uh-huh, good. And a little traction, more traction than anything. Shot. Nice. Shot. Come on now, almost there. Shot. Yes. Done. Good job, everybody. Relax. We're there. Now let's just get that dilator out without taking the tube and we're fine. Work it, girl. All right, any questions from our audience?
No current questions, Dr. Deuk.
All right, good job, Luis. Why don't we go ahead and do this? Let's run the video of Deuk laser disc repair versus fusion one more time so everyone can see the difference. I hear something dripping over here. Oh, great. We're dripping like crazy. Get a hemostat. Here. Guys, let's get all that cleaned up. I don't want those machines broken. How'd it come out? Any questions from our audience? Are you running the video? Yeah, I wouldn't double it. I would just increase it a little bit more. And maybe put a hemostat on that nipple next time. All right, I need the video, the endoscopic video. Do I have irrigation or no? It doesn't look like it. I need irrigation, guys. Perfect, thank you. All right, nice work. Here we go. Last disc. Yeah, so you can see the scar tissue here is massive. This is a very badly damaged disc. This is as abnormal as it gets. All right. So it's going to take me a little while. This is all scar tissue and bone spur. I'm going to have to flip back and forth a few times, but hey, at least we're here. We're getting it done, and that's the good news. I had my doubts. I think Luis had his doubts. But you know what? This is great. Great to see. Okay, we got, I would say, 5 to 10 minutes max, doctor. So we'll be done. In terms of your anesthetic. Flynn, let me know how much time you got left. I'd say 5 minutes, we'll be done. I'm sorry, what did you say? It's up to you. I don't want to manage that part of the surgery. I need 5 minutes. You think he'll come off the table? This is so bad. Fuck, Luis. I can't even tell what the hell that is. That's all bone. But what is that down there? It almost looks like it should be spinal cord. But it's all scarred deeply, 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 right? See that? It's all bone spur. I mean, that to me looks kind of like either PLL or Dura, and then what's this shit right there? Oh, that's herniation. That's incredible. Fucking hell. That's so bad. 10 minutes. Sorry. I've never seen anything like that. I've been doing this 16 years. I've never seen anything like that. Can we look at that disc, that level? That's the craziest thing I've ever seen. Look at it just digging into the spinal cord. Fuck me. Fuck. Right side is there. That's the side he's having the most symptoms. How's my irrigation? A mess?
It's fine. It's good now.
All right, good. Now this is like the worst I've ever seen for the scope. All right. What in the fuck is that? It's literally a bone spur and scar tissue on top of the spinal cord. Fuck me. That's all scar tissue from the... Are we back yet? Hello, McFly.
Yes, Doc.
Are we back?
Yes.
Nice. When did we come back? Did you get all the fuck me's that I had? Just want to make sure. So basically, are they able to hear me?
Yes, they could hear you.
All right. So this is the 6-7. I've never seen anything like this. Then again, I've never done surgery after another surgeon's total destruction of one side of the spine at 6-7. This is all scar tissue, and that's pushing on the spinal cord. I mean, it's literally either out in the foramen or spinal cord, and that's all bone there. You can see the spinal cord just at 6 o'clock from the laser fiber. This is all scar tissue from prior surgery. This thing has done so much damage. It's no wonder why this patient's having a lot of symptoms. This is all on the right side too. This is where most of his symptoms are. So anyway, we're going to do everything we can to get the pressure off the nerve and spinal cord, but that's all scar tissue down there, right there. So hopefully we can get enough of it to make him happy. I have to have my limits on what I can do though, as long as it's safe. That's all scar tissue. This is the foraminotomy he had done. It's on the right side. That's the side that he had it done. And it's no wonder why he got worse. Look at this thing. This is all scar and disc reherniation. It's terrible. I don't know if he just lifted something too heavy afterwards, but this is just one of the worst I've ever seen. That's a giant bone spur. What a mess. What a stinking mess. Yeah, that's all scar tissue here. You can actually see the dura down there. This is the most precise surgery that can be done in the world right now, because the laser delivers 0.5 millimeter depth of energy. So if you want to protect things like nerves and spinal cord, this is the perfect tool. If we did this as an open surgery like an ACDF, I wouldn't have been able to see even with as much detail as I can see right now. Just being right on top of it. Oh. Wow. I think that's scar tissue right there. I'm going to try to work it from the other angle. And we're running up against his chest here with the irrigation. Can you help me with that, Luis?
Yes, sir. Yes, sir.
Look at that scar tissue. It's crazy. That's why he's having so much symptoms. Okay. I'll try to kind of limited because this is the lowest disc and his chest is literally pushing on me. Anyway, that's incredible. I've never seen. This is all damage from the first surgery. What's wrong? You guys okay? We can get a little more and then we're done. I don't want to risk causing any problems. We've gotten the herniation out. That's what was sitting there before. But now I'm trying to clean up the bone spurs and scar tissue. It's sitting on top of the spinal cord and nerve. And you get to a point where you can't do anymore when it's this bad. You can see the spinal cord down there, right next to this spur. So I'm going to try to take a little more of the spur out, and then I'm done. I don't want to cause any problems with the spinal cord or nerves. All right. Well, pretty bad. This is totally abnormal. You never see this. This is from prior surgery. This doctor drilled a huge hole here and left basically fragments of bone. It wasn't me. I'm trying to help this guy and fix it, but there's only so much you can do. You don't want to cause more problems for the patient. And I feel like we've taken off as much as we can here. So, all right. 1 minute left. How are we doing on irrigation? Huh? Oh, I'm done. Yeah, this is just one strand of scar tissue over the spinal cord. That's as good as I can get it safely. All right. All right, let's show our audience in just a moment here the two incisions we used. Again, we're using an antiseptic here called betadine, developed by NASA to stave off any kind of infections. It's the best antiseptic we have. It's very safe to be used. Great. So let's get a little lighting on. We can show everybody. So can you see this here?
Yes, we can, doctor.
The whole surgery was done through this little metal tube. I'm going to pull it out, and it went, from the front, which is the right way to do this. The problem is your surgeon where you live won't know how to do this surgery. It's a new technology. It requires advanced training and advanced unique equipment. All of this is FDA approved. They'll just give you an idea. This is the scope we use. You can see it's got a long shaft with fiber optics. It's got irrigation, a port for the laser, and a port for illumination, which is the light source, and then the camera attaches to the back. So it's, most hospitals have a small budget for equipment, on the order of maybe for spine surgery, let's just say they may have a budget annually somewhere around $20,000 to $50,000. That wouldn't get you, you know, 2 scopes really and the equipment, the tools that are necessary. So to be able to run a program where you do endoscopic spine surgery, it's just cost prohibitive. Okay, can you see the incisions?
Yes, we can see them, doctor.
All right. Everything went perfect. Better than I expected. We got everything done I wanted to. And I saw a lot more scar tissue and bone spur damage at the bottom disc than I expected. But that's why you don't rely just on the MRI. You go inside and look and see, and that's what we did. I feel really good. I think he's going to do very well. We took out a lot of herniations. Go ahead and type up your questions for me, and I'll be coming and answering them for you. Dr. Deuk here at Deuk Spine Institute. It's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
Severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy, 2 spinal injections, massage therapy.
And how did you know those treatments did not work for you?
I had no relief at all. My sleeping continued to get worse, and my pain was never better.
And do you have relief now?
Absolutely. I would say I have 95% relief.
Awesome.
And it's amazing. After surgery yesterday, I put on a back brace. I walked out of here. I sat down yesterday for probably over an hour and had lunch. Last night, in bed, I had 0 pain. It's a miracle.
Well, we're very happy that you're doing so well. And your surgery was a great one because we fixed 2 discs. You had herniated disc at L45, L5S1, and you can see in this footage right here that we grabbed the herniation out, and it was one of the herniations was really big, and it was really gratifying to get it off because it was resting on your sciatic nerve. Once we took it out, I think your sciatic nerve probably felt a sigh of relief.
Yes, absolutely.
Yeah, and the surgery went very well. The laser debridement of the annulus went well, and I feel like your pain's going to be gone. It's not going to come back.
I would agree.
All right, very good. Well, is there anything else you want to tell your viewers?
Folks, if you're suffering and you're not getting relief from those non-invasive therapies, then come see Dr. Deuk and have him look at your MRI and give a diagnosis. And if you need to have surgery, you come down here. He will take good care of you, and so will his team.
I really appreciate that. Thank you so much.
Thank you.
I'm Dr. Deuk. It's January 26, 2022, and I'm here with one of my patients who you underwent the Deuk laser disc repair on your lower back for some herniated discs about a week ago.
Yes.
How are you feeling today?
Unbelievable. For almost 3 years, I had lower back pain, and it just, it just nags at you, wears you out. And then I came here, and you were the first one. I went to 2 other surgeons, and neither one of them picked up what was wrong with me, even though I had the MRI. And you came in, and you told me exactly what was going on, and you performed the laser surgery, and I'm like a different person.
Yeah.
A week later.
Yeah, you were a different person the next day, right? The day after, you had no pain, remember?
No, absolutely.
Yeah, so that pain's gone for the rest of your life. How does that make you feel?
New life.
Good. And you know, a long time ago, remember when people did something great, you say, what are you going to do now? They say, I'm going to Disneyland. You already went, I can see.
No, my wife's a big Disneyland fan.
Good for you. All right, so sounds like we helped you with your back pain, and it sounds like you're very satisfied.
Oh yeah, I'm recommending a friend of mine in Connecticut to come here. You have to come here. If you go anywhere else, I really think you're going to be wasting your time. So this guy just looks at you and he can tell what needs to be done. He's a fantastic talent, and I'm very grateful that I came here.
Well, we're grateful you did too, because it's going to change your life for the better. Congratulations.
Thank you, Doc.
You're welcome. Good morning, I'm Dr. Deuk Major. I'm here with one of my patients, and you traveled to Deuk Spine Institute here in Florida from where?
New York, Poughkeepsie, New York.
Awesome. And why did you come from New York to Deuk Spine here in Florida?
Because I heard that this was the best place for me to go.
What kind of problems were you having that you needed to come here?
I had lower back problems and numbness in my leg, which was my left leg. This was the best place for me to come.
Okay. So you had back pain, sciatica down your left leg, pain shooting down the left leg.
Yes.
And that was just yesterday, right? When you
yes,
had
that's
that.
correct. Yeah.
And what, do you still have your back pain today?
No more back pain.
It's gone.
Gone.
And is that because we have you doped up on powerful painkillers?
Nope. None
No, it
whatsoever.
isn't. Did anybody in New York offer you spine surgery to fix your back?
Yep. Yes, they did.
Yeah.
And they wanted to fuse it.
Yeah. And you've had surgery before. You had a microdiscectomy, and that helped you for a little while?
Yes.
But the symptoms came back.
Came back.
Yeah. All right, well, they're not going to come back this time. So what do we do to make your pain go away?
You fixed my back. I did orthoscopic.
That's right, arthroscopic spine surgery called the Deuk laser disc repair. So leg pain's gone, back pain's gone.
Everything is gone.
You happy?
You did. Very happy.
You're smiling.
Yeah, I tell you.
Congratulations.
Thank you so much.
We did it all through a 7mm incision, just that big. And you can actually watch that video right here, an animation, to see what it looks like to do the Deuk laser disc repair.
A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own.
So now that your surgery's done, what are you going to do?
I'm going to go home and enjoy my life.
Good for you.
Enjoy my life.
Congratulations.
I'm very happy.
Anything you want to tell your viewers?
Other than this is the place to come, it's worth the travel.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, Submit your MRI for a free review at www.mri.deukspine.com.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving
C3-C4, C4-C5, and then we had more degenerative disc disease at C5-C6 and severe scarring and C6-C7 on the right side from his prior surgery. Now he had bad scarring at C5-C6 as well on the right side, but it was far worse at C6-C7. I think that the surgery must have created some instability for the patient, and that instability over time has just caused the joint to crumble on that right side. The good news is I cleaned out about 80% of that scar tissue and bone and disc herniation at C6-C7. I cleaned out 99% of it at 5-6, 4-5, and 3-4. So overall, I feel very good about the surgery. I think he'll be very happy. We do have a question from our audience. They're asking if we can do an interview of the patient after surgery. Yeah, that's up to the patient. We can ask, but some patients don't want to do interviews, and that's fine. And that's about 50-50. Not because they're not doing well, they just don't want to do an interview. On the other hand, we need a videographer to do the video interview. We don't have a videographer, so I can tell you with certainty that we won't be doing a video on this patient. Our videographer, Kevin, went off to take another job that pays more, and he left on Friday, so we haven't replaced him yet. We should have a videographer probably in the next month. That said, you probably won't see any testimonials probably for the next month, just because we keep losing our videographer and replacing it with a new one. There's just high turnover. The Great Resignation affects us as well. Anyway, that said, if you would like to have your MRI reviewed or know somebody that wants an MRI review, feel free to submit it at mri.deukspine.com. It's a free service we offer. And other than that, we'll be back in about 30 minutes with our next surgery. The next surgery will be a Deuk laser disc repair in the lower back on a patient who's over 80 years old, and he came to us with herniated discs at L23, 34, 45, 51 on the right side and on the left side, with pinched nerves on both sides and neurogenic claudication. He had the left side fixed already on Tuesday, and he's doing really well from that with respect to his pinched nerves. Symptoms have almost gone away. He does have some facet pain, which we're going to be treating, and he's got muscle soreness on the left side. As far as the right side goes, we're treating that next, so stay tuned. You'll see just how much degenerative disc disease this patient